2026. So see what happens, like systolic, when should you start the medical management? Systolic BP should be more than or equal to 140, and or a diastolic BP of more than equal to 90 mmHg. So why have they written here and or? Because see what happens, that now they have recommended use of antihypertensive even if there is isolated systolic hypertension to avoid complications. Okay, so even if like the BP is somewhere around 150 80, then also you're supposed to start antihypertensive treatment because this is isolated systolic hypertension. Okay, now talking about antihypertensives for non-severe hypertension, first is labetalol. Okay, this is of course the first line effective medication preferred when pulse is more than 100 per minute. Okay, remember this. Now the starting dose is 100 to 200 mg BD or TDS, gradually increased to achieve optimal control of BP. See, so second antihypertensive, when should you add? Once you have reached 1200 mg per day dose. Okay, maximum which you can give is of course it is 2400 per day, but once you have reached, once you're incrementing it and you have reached 1200 mg per day, you need to add second antihypertensive. So what are the disadvantages of labetalol? First of all, it is contraindicated in asthma, congestive cardiac failure, diabetes, and bradycardia. Okay, that's why we had made this that's why we told that baseline pulse should be more than 100 to start labetalol. This is a very important point. Okay, and coming to disadvantages, it can of course cause neonatal bradycardia and hypoglycemia, which necessitates monitoring. Talking about second drug which is available is nifedipine. This is the drug which is preferred when baseline pulse is less than 100 per minute. Okay, the starting dose is 10 to 20 mg of slow release preparation, BD or TDS, per day. Maximum dose which you can reach is 120 mg per day. And what are the disadvantages? It causes maternal tachycardia. That's why you have to start it only when baseline pulse is less than 100 per minute. It can cause palpitations, headache, facial flushing. It should never be given sublingually. This is very important. This should never be administered sublingually, and it is contraindicated in aortic stenosis. Coming to next drug, that is methyldopa. This is of course most time tested and safe antihypertensive. Starting dose is 250 to 500 mg per day, orally TDS or 4 times in a day. The maximum dose which can be reached is 2250 milligram per day. Disadvantage is just depression and postural hypotension. And this is a very important question. Target blood pressure to be achieved is 135 by 85 mmHg, right? Other drugs which are available, they actually have very limited trial data, and one of them, that is oral hydralazine, it causes maternal tachycardia. Okay, and others of course you know that okay, so talking about oral antihypertensive in labor, suboptimal BP control is there because of decreased gastric absorption. So that is why always in labor you have to give parental antihypertensive. Okay, right. Talking about severe hypertension, where systolic BP is more than or equal to 160 and diastolic is more than equal to 110. So first line in this is of course your IV labetalol. Okay, there you have to give slow IV injection 20 mg initially, then you can double every 20 to 30 minutes, you can go up to 80 mg. Okay, if BP is not controlled. Maximum dose which you can give for IV labetalol in severe hypertension is 300 mg. Alternate IV infusion regimen after initial loading dose. And so what you can do, this is actually the loading dose. Okay, then you can check the BP in every 20 to 30 minutes. If it is not controlled, you can double it up, and you can double it till the time you've reached 80 mg. Okay, another alternate regimen which is available is continuous IV infusion. Okay, what you do in this, you give an initial loading dose, and then you can just start an infusion at the rate of 1 to 2 mg per minute. Okay, and contraindications again same, congestive cardiac failure, diabetes, asthma, and bradycardia. Now coming to oral nifedipine. Oral nifedipine is given 10 to 30 mg orally, and remember, you never have to give it sublingually. Okay, if BP not control, it can be repeated within 30 to 45 minutes. Maximum dose which you can give is 120 mg. Right. Once controlled, slow release preparations are to be started, and contraindications, congestive cardiac failure, AV and SA node abnormalities. Third drug is IV hydralazine. Okay. Here you have to give 5 mg IV or IM, then 5 to 10 mg every 20 to 30 minutes. Once BP is controlled, you have to repeat every 3 hourly. For infusion, this is the dose which has to be given, 0.5 to 10 mg per hour. Okay, and if BP is not controlled, then you have, if BP is not controlled with 20 mg IV or 30 mg IM, then you need to consider another drug. Okay, right. So what are the contraindications for IV hydralazine? It is associated with maternal and perinatal adverse effects than intravenous labetalol or oral nifedipine, such as maternal hypotension, cesarean sections, placental abruptions, and oliguria. Now the fourth drug which they have approved for use in severe hypertension is actually IV nicardipine. Okay, the average starting dose is 1.5 mg per hour. It can be increased up to 6 mg per hour for desired effect according to 0.5 microgram per kg per minute. Okay, what are the contraindications? 100 times more water soluble than nifedipine, so it can be administered IV, making it easily titrable. Okay, so calcium channel blocker, we had nifedipine also and nicardipine also, but nifedipine you have to give orally, whereas nicardipine you have to give IV because it is 100 times more water soluble. Okay, so easily titrable. Right. So target BP to aim for is 140 by 90 in case of severe hypertension. In non-severe hypertension, it was 135/85. Okay. BP should of course be lowered promptly but slowly. Right. Okay. For seizure prevention, we all know magnesium sulfate, and you have to give in all cases of severe preeclampsia, you have to give the loading dose followed by maintenance dose for 24 hours. This we all know it. And also you should know that it will also have neuroprotective effect for pregnancies between 26 to 32 weeks. Okay, and one update which they have given here in Fogsi 26, that oral nifedipine and magnesium sulfate can be given concurrently. Right. Okay, now coming to antihypertensive drugs to be used in refractory hypertension. Okay, first is nitroglycerin and second is sodium nitroprusside. This is in refractory hypertension. Talking about nitroglycerin, it can be the starting dose is 5 microgram per minute, and it has to be increased every 3 to 5 minutes by 5 microgram. Okay, depending on BP response and symptoms. So what is the contraindication? It can be used in monitoring setting only when there are severe refractory pulmonary hypertension and pulmonary edema. Talking about sodium nitroprusside, IV infusion of 0.5 to 4 microgram per kg per minute, and then titration to desired effect. It can actually rapidly reduce hypertension. Contraindication, it is used in refractory severe hypertension in a monitored setting. Again, same. You have to use both of these drugs in monitored setting. Okay. Yeah, and then it causes peripheral vasodilatation of both arteries and veins by producing nitric oxide. It can also produce cyanide toxicity and severe side effects if not monitored. Coming to postpartum hypertension, during the hospital stay, blood pressure should be closely monitored for first 48 hours. Okay, post delivery you have to monitor it for 48 hours. Antihypertensive used in antenatal period should be continued. You don't have to stop them erratically. Antihypertensive therapy is recommended for persistent BP of systolic blood pressure of more than 140, diastolic of more than 90. Persistent BP of more than equal to 160 and or diastolic BP more than 110 should be treated within 1 hour. Okay, and magnesium sulfate should be considered for seizure prophylaxis. Okay, right. Now fluid management, total fluid restriction, all inclusive, it is 80 ml per hour or 1 ml per kg per hour is recommended. Preloading is not advisable in preeclampsia. Crystalloids like Ringer's lactate or normal saline can be used. Fluid restriction is advisable to reduce the risk of fluid overload in the intrapartum and postpartum periods. Inappropriate use of fluids can cause pulmonary edema and maternal death. Coming to point of care ultrasound, it can be used as a non-invasive rapid method to assess fluid responsiveness, which is very important in management of fluid therapy in hypertensive disorder. It can be done for evaluation of IVC, lung left ventricular outflow tract. It can predict fluid responsiveness, and ultrasound of the lung can identify early development of pulmonary edema. So point of care ultrasound is very important. PCP/NDT rules for usage of ultrasound in such indications must be followed according to the guidance of appropriate authority. Okay, intrapartum care for preeclampsia and eclampsia. Severe hypertension is a surrogate marker of adverse maternal and perinatal outcomes and should be treated aggressively to reduce severe maternal morbidity, of course. Okay, in patients with hypertensive disorder, hourly BP recording in labor is recommended. So what is the frequency? Hourly BP recording. If BP more than 160, 110, repeat BP every 15 to 30 minutes until reduced. Continue antihypertensives in labor after the initial dose at appropriate interval. Antenatal corticosteroids, they are recommended in following situation: if there is established preterm birth, labor with contractions, preterm pre-labor rupture of membrane, situation where decision for delivery is taken for maternal or fetal indications. Do not delay delivery solely to complete the course. Even a single dose before birth reduces respiratory distress syndrome. Okay, gestational age, if we see what are the recommendations, it is recommended between 24 to 34 weeks when birth is expected within next 7 days. Rescue course, only one repeat course. Remember, only one repeat course. It is important to know, only one repeat course if birth is imminent and previous dose is more than 7 days back. Okay, now 34 to 37 weeks, which you call late preterm, routine use is not recommended, and 23 to 34 weeks also individualized decision should be taken. And of course at term you don't have to use to hasten resolution of HELP syndrome. So in India, Government of India has recommended dexamethasone 6 mg IM every 12 hours into 4 doses. Okay, caution, you have to maintain caution in hyperglycemia, admission and intensive glucose monitoring may be needed, right? So magnesium sulfate for fetal neuroprotection, it is indicated when very preterm birth is imminent. Okay, reduces risk of cerebral palsy. Now for this you have to deliver the baby before 32 to 34 weeks. Okay, again same start MG when preterm birth is expected within 24 hours. Here you have to give when birth is expected within 24 hours, whereas antenatal corticosteroid for lung maturation you have to give when birth is expected within 7 days. Okay, right, or decision of iatrogenic early delivery has been taken. Ideally it should begin 4 hours before the birth. Okay, but given if even if delivery is sooner, because some benefits might persist, right? So dosage is 4 gram IV loading dose over 20 to 30 minutes followed by 1 gram per hour IV infusion. Continue until delivery or up to 24 hours. Stop after 24 hours if undelivered. And